Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode.
Hello, everyone. Welcome back to another 10 clinical minutes, part of our OB series. So today we're going to be talking about hypertensive disorders of pregnancy, focusing on gestational hypertension, preeclampsia, and eclampsia. So just basic physiology of blood pressure in pregnancy. Generally in the second trimester and in the early pregnancy, you see a decrease in peripheral vascular resistance, which also causes a decrease in blood pressure, which is physiologic. Sometimes women who are on blood pressure medication may need less of it during pregnancy because there's a normal decrease. But then towards the end of pregnancy, PVR continues to increase. And then also you see the MAPs also begin to increase as well. And so you have a normal elevation of blood pressure towards the end of the pregnancy, which is often when you see most of the symptoms of hypertension in pregnancy. So some definitions. This is a crowded slide. Pause it, take a chance, look at it, read through it. We're focusing on the ones in yellow: gestational hypertension, preeclampsia with severe features, and eclampsia. So to start with some definitions, gestational hypertension, blood pressure greater than 140/90, developing 20 weeks after gestation. This is opposed to chronic hypertension, which is if it exists before 20 weeks. Preeclampsia is gestational hypertension with one of these features: proteinuria, thrombocytopenia, renal insufficiency, transaminase, pulmonary edema, or headache. Preeclampsia with severe features is preeclampsia, so gestational hypertension with one of those features, but the blood pressure is greater than 160/110. Eclampsia is a seizure during the pregnancy or immediate postpartum period, which is often something that people don't think about, is that eclampsia can happen afterwards. The same is also true with HELLP syndrome, that you can have it either pre or postpartum. So often talked about as a spectrum of disease, that you have gestational hypertension, progresses to preeclampsia, becomes severe features, and then progresses to HELLP syndrome or eclampsia. 3.2% of preeclampsia severe features will progress to eclampsia. Sounds bad. But 1.9% of preeclamptic patients will progress before they have severe features to eclampsia. And further bringing the spectrum of disease into question, of eclamptic patients, 38% in the UK study occurred without documentation of hypertension or proteinuria. And with HELLP syndrome, 15% lacked either hypertension or proteinuria, really drawing into question whether or not this is a spectrum of disease or if it's a pathophysiologic process that can happen independent of the other components of the disease and present rapidly before being able to be diagnosed by the healthcare system. So we move on to physiology. This is for preeclampsia related to gestational hypertension. Obviously, you can have preeclampsia related to chronic hypertension, and that can have a myriad of factors causing the hypertension related to the person's ongoing disease. Specifically related to gestational hypertension, it seems to be strongly indicated that's related to pathophysiology in the placenta, causing a failure of remodeling of the spiral arteries, which increases peripheral vascular resistance because normally this is a low pressure circuit and causes for the overall blood pressure to increase. There are many contributors to this function, whether it be genetics, abnormal trophoblasts, altered immune systems, increased angiotensin II antibodies. It's beyond the scope of today. There's some great review articles, especially this one that's referenced here, number 3 at the end of the slides. But the result is that you have increased distress, pro-inflammation, which is part of what causes the platelet aggregation throughout the body, increased angiotensin II antibodies, which causes for increased peripheral vascular resistance. And then the syncytial trophoblast microparticles are also prothrombotic, which explains kind of why you see some of the platelet sequestration in the thrombocytopenia for preeclampsia and also for HELLP syndrome. But hypertension and platelet aggregation is an adaptation to the ischemic uteroplacental unit. It's not the cause. And so the defect here in the uteroplacental interface is not the cause of hypertension. It's independent on its own, but this defect here ends up causing hypertension and that platelet aggregation as we talked about. So risk factors, aspirin prophylaxis. Aspirin is the drug choice for preeclamptic prophylaxis. If someone's in the high risk category, previous pre-E, multifetal, chronic hypertension, type 1 or 2 diabetes, renal disease, or autoimmune disease, they get an aspirin. If they're in this moderate risk, you can consider it. And if they're in the low risk, which really just means a previously uncomplicated full-term delivery, they don't need an aspirin for prophylaxis. So pause, look at this. You can review it as you see fit. So how do you manage it? You have a sentinel event. the preeclamptic symptoms or the elevated blood pressure. Sometimes they'll happen in triage, sometimes they'll happen in an outpatient visit, and you'll send them to triage. Then you do your workup, you repeat the blood pressure, you put them on a monitor for fetal heart tracing, so you can see our other video for that. You do fetal ultrasonography to get the weight, amniotic fluid index, urinalysis to check for proteinuria, CBC-CMP for anemia, thrombocytopenia, LDH, another marker of anemia, and then angiogenic factors, which is one way to predict pre-E, but not available here in the US. Then you have to decide how to manage it. If it's just gestational hypertension to pre-E severe, it can take 1 to 3 weeks to progress. But if it's pre-E to pre-E severe, it can take days to progress, which is why we're more aggressive. If they're after 37 weeks, we deliver. If they're less than 30 weeks, we try and get them to 37 weeks. But if it's pre-E severe features, then we would deliver as well. And so these are some of the weekly routine that you would do for the patient, just to make sure that everything's still going fine. Once they develop features significant enough for delivery, you need to deliver. The magnesiums for prophylaxis, and then try and control the hypertension with these agents here. But if you have severe hypertension and you have the preeclampsia, then you would need to treat different. So how do we do magnesium and why do we do it? The number needed to treat is fairly low for the number of women who have hypertension in pregnancy. Just for pre-E, 112 to 129, for severe, 36 to 160 in order to prevent a seizure. If the patient becomes toxic, you correct with calcium gluconate, and this is the dose. And you continue the magnesium for after delivery for up to 24 hours because eclampsia can happen post-delivery. Dosing's on here as well. You would do mag checks to test because you can see that you lose patellar reflexes before you get to respiratory paralysis and before you get to cardiac arrest. So if a woman is areflexic, you would want to either hold the mag and correct with calcium gluconate because it indicates that you're getting out of the therapeutic range and into the toxic range. So what do? Your patient in 24 is seizing. Basic supportive measures for someone who's having a seizure. Help, prevent aspiration, give oxygen, monitor vitals, and put them on the side. For a pregnant patient, that's to relieve pressure on the IVC. Generally, these seizures are self-resolving. You continue MAG after the seizure abates, and the seizure is not an indication for emergent delivery. You need to deliver soon, but you can choose vaginal with an induction or cesarean based on maternal factors, as you would normally choose to deliver between a vaginal and cesarean section. So what are our key points? You treat blood pressure greater than 160 over 110, magnesium sulfates for prophylaxis. After 37 weeks, deliver. If severe, deliver when they show up. Don't get in a rush to deliver a patient, but follow normal indications for vaginal versus cesarean. And it might be a circular spectrum of disease rather than a direct. Thanks for joining us for 10 clinical minutes. Here are our references. They're indicated on slides, and you can follow them up here with either the up-to-date articles, PubMed IDs, or the practice books in ACOG. Thanks for joining us. We'll see you next time.